Thank you so much, Justin. Hi there, everyone. My name is Pam Yankee Love, and I'm the Director of Research and Evaluation at the University of Louisville Traeger Institute. And we provide Project ECHO to you in partnership with the Kentucky Coalition for Healthy Communities, KCHC. Project ECHO, the care of older adults. And we are glad you are here today. All right, just a few tech tips. If you can go on and turn on your mic, your video, please go on and turn on your video so we can see you in our learning community. And we ask that you go on and check your microphone to see if it's functioning. If it's not, there are some ways going on and clicking on that little caret to check to see if you get your microphone to function. If not, go on and join us via your phone. You can do it through your Zoom app, or you can just go on and call in. You can take a picture of that before we go on to the next slide. You don't want to lose you. All right, so as I said, Project ECHO is brought to you by the University of Louisville Traeger Institute and the Kentucky Coalition for Healthy Communities. And if you're unfamiliar with KCHC, I think Justin is going to do a little overview of KCH's mission.
Thank you, Pam. So the Kentucky Coalition for Healthy Communities, intention is to create community support systems for older adults in partnership with existing local coalitions and organizations. So we always invite you to Project ECHO to share about what you're currently doing and to develop the workforce and concerned community members to empower our communities to become healthier.
Thank you. And if you guys are not familiar with the concept of a Project ECHO has actually been going on for 20 years. Thank you, Justin. He shared that with me today. And it was founded by Sanjay Arora, who is an MD, who's a hepatitis C expert. And he had individuals, his patients, that were driving between 200 and 300 miles to receive his expertise. And he didn't feel that he was creating local capacity, so he decided to develop this Project ECHO platform. And it is a telementoring platform, and there's usually a rhythm to this platform in the sense that there's usually a didactic, then there is a case, and then we learn together. It's a teach all, learn all space. And the idea is to not move patients, but to move knowledge so that we can build capacity at a local level. So in our Project ECHO, we're teaching best practices in interdisciplinary team-based care. So everyone in our Project ECHO is very, very valuable to the experience. And we hope that we all share our experiences and our knowledge with one another as we progress today. Right now, we do go on and ask that we take attendance. We're asking that you go on and type your name and your organization in the chat box. So I'm going to go on and do that. Should have already done that by now. There we go. If I can spell institute. And this helps us get a better sense of who is in our learning community. And so we can get to know each other. And if you haven't done so yet, go on and put your name. And if you can squeeze in your organization underneath your name in your video square, that would be great. Just go on, and the way to do it is go on and click on your video, and there's three little dots. And there's a dialog box that comes up. You can hit rename and go on and change your name. You can add your organization and even your pronouns. And today's presenter has nothing to disclose. And if you are a community health worker, we do have approval for receiving 1.5 CEUs if you are a certified community health worker. So you want to make sure you stay on to complete that survey at the end. And if you are would like a certificate for today's attending today's session, you can go on and receive that as well, making sure to complete the evaluation at the end of the session. And those individuals that are community health workers, you must go on and complete that evaluation to get that CEU. All righty. So today we have Lafayette Brown III, who's going to talk to us about trauma and its effects, an introduction to trauma-informed care. And Lafayette is a social work clinical case manager in the post-9/11 military to VA case management program at the Louisville Robley Rex VA Medical Center. Before we go on and hand the mic over to Lafayette, I just want to share a little something about Lafayette. So Lafayette Brown III is a licensed clinical social worker currently working at the Department of Veteran Affairs in Louisville, Kentucky. He served in the U.S. Army, thank you so much for your service, receiving a Bachelor's of Arts in Human Services and Counseling from Lindsey Wilson College, and a Master's of Science in Social Work from the University of Louisville. I also hear he's currently in the DSW program at the University of Louisville. Lafayette has experience in direct clinical patient care, crisis management, individual and group therapy, public speaking, and facilitating connection to community resources. So Lafayette, we appreciate you coming here and sharing your expertise, and I hand the mic to you when you are ready.
Thank you so much, Dr. Yankee Love. And thank you everyone for being here. I do appreciate this opportunity to kind of talk to you guys about trauma-informed care. It's definitely one of my passions. It's a work of passion, I think, that I've squeezed into my new role, which has changed since I talked to Justin. Now I'm the General Caregiver Support Program Coordinator, which I am working with caregivers who are for veterans. So I'll probably be connecting with you guys more and more for more resources, just community resources, in addition to the VA resources. So today, what are we going to do today? Well, first, I want you to be able to, at the end of this, be able to identify the types of trauma, ACEs, and then the prevalence of trauma that we have within our world and in our community. Understand the concept of trauma and trauma-informed care. And then I want you to develop a general understanding of ACEs and the impact it can have on development. Now, I like to do this to create kind of psychological safety. And I think it's really important that I demonstrate this to you guys because I do it before every meeting. And so I will choose Dr. Yankee Love. And if you would, please, just Dr. Yankee Love, ask me these questions, and then I will explain to you why I had her asking me these questions.
All righty. Do you want me to go through them, or did you want
Yes,
to?
one at a time from top to bottom.
So how am I feeling today? I'm feeling peaceful.
I'm sorry, I misunderstood.
Oh.
Ask me the questions, then I'll
Oh,
answer.
you want me to ask you? Oh,
Okay.
All right, Lafayette. How are you feeling today?
I'm nervous. I'm mostly nervous before these presentations, which lets me know I'm right where I need to be. So I'm excited as well.
Okay. And what is your goal for today?
My goal is to talk to you guys about my passion, trauma-informed care, and hopefully it's something that you can incorporate in your daily activities and overall maybe in your policies and procedures when dealing with clients and patients.
We look forward to that. And who will you ask for help?
Well, I will ask you for help because you did help me here. Then I can ask Justin, he's already helping me as well.
All right.
All right. So quickly, why did she ask me those questions? What was the point of that? Well, when you ask someone how they're feeling, what you're trying to get at is their emotional intelligence. How can they describe, instead of I'm fine or I'm good, you know, some of those feeling words that really show where they're at, like I'm nervous or, you know, I'm happy or I'm excited. So we're gauging the emotional intelligence of the room. The second question is a focus on the future. So what is the hope that you have moving forward? And then the third question is just to create a connection to the community. If I needed help, if I wanted help, who could I reach out to? And so these are things that we ask every time before we do a training of each other, the trainers and even the audience member, just so we can kind of create that space where we can have open dialogue and free information exchange. So what is trauma? I like this definition because it really explains the basis of it. It comes from an event or a series of events, right? Or even circumstances experienced by an individual, myself, by a group or community. Think of 9/11, it was experienced by everyone, as physically, spiritually, and emotionally harmful or life-threatening. That doesn't necessarily have to be life-threatening. I wasn't threatened by 9/11 here in Kentucky. However, the fact that it happened on American soil made me feel threatened by it could happen anywhere. And so all we have to do is just feel like our lives were threatened or something was threatening our safety, and that can cause us some form of trauma. And it has adverse effects, of course, on our functioning, mental, physical, social, emotional, spiritual well-being, as well as our ability to feel like we are safe. So when that safety, our feeling of safety is removed, in any situation, you can almost guarantee that there was some sort of trauma experience there. Types. What are the types of trauma? Well, there are many, many types of trauma, from physical, psychological, spiritual, military trauma, which includes moral injury for those of us who were deployed and had to do some things because our job told us to do it. Gender trauma, we talk about that all the time with IDEAL, you know, with gender identification and getting those concepts kind of pushed forward into the mainstream. Developmental trauma, intergenerational trauma. So, poverty is one thing I think that is an intergenerational trauma. It happens to parents or grandparents, and trauma in and of itself can be sexual, racial, or transgenerational. So I want you to kind of think of trauma not just as PTSD, right, but as this event that happens to each and every one of us on many scales, all the way up and down the continuum, and can be any flavor or any color. So trauma is just an event that happens to us, again, that we feel like changes our perspective or changes us in a way where we no longer feel safe. So to break that down even further, so we talked about the events, right? The experience, again, the experience is what matters, because we have to determine whether it was traumatic to us or not. Did it change the way we feel about our safety or what's going on in our lives? And then the effects, right? They can be adverse. They don't have to always be physical. They could be just social. I withdraw from a lot of things because I had a bad experience when I tried to step out and go and interact with other people. It could be emotional, a bad breakup could cause you emotional trauma, or even spiritual consequences. Think about the time when they were offering to, for our LGBTQ, some churches were offering, they could, I can't think of the term right now, but they used to offer training where they can get it out of you in God's name or something like that, right? That's spiritual trauma, right? So all of these different things happen, but the 3 E's are very important when we're thinking about, did trauma happen? So how prevalent is trauma? Well, some reports say that at least 47 to 81% of persons polled in this poll said that they experienced some sort of trauma, right? The red indicates the areas where the highest levels of trauma were recorded. And then as we go up, yellow and green, they were lower. But as you can see, America reports a lot of trauma based on this poll. And so what are we saying? Well, we're saying that if it's this prevalent in our community, it is a global epidemic. What are we doing about it? What can we do as providers in our space, in our zone, in our work area, where we can help someone who's had some sort of trauma? Now, the next slide is going to talk a little bit about trauma as it relates to early childhood experiences. But keep in mind, trauma is just not in childhood. It can happen to us anytime throughout our adulthood, our teenage years, and our young adult years.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems, and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
I really like that video at the end because it says something that's very important that I want you guys to take away. ACEs is not a sentence that you will definitely have one of these negative health outcomes. It's just something that indicates that you are at a higher risk. And so the ideal that he said about the students is very important, which is what I teach at the VA, is what happened to you versus what's wrong with you. So what we're doing is we're separating the problematic behavior from the individual. One of the things that I like about that is that when I worked in substance abuse, you know, I didn't talk to alcoholics. I talked to people who were suffering from alcoholism, right? So again, we can kind of tease out these risk factors, these things that happen, these traumas from the person themselves, and empower that person to have a better life for themselves once they understand why they're having the reactions that they have. So what does that sound like? Well, if you've had a traumatic event, it sounds like before I got into the car wreck and then after I got into the car wreck. So before, and this is my example, and I love to put personal stories in this. Before I was rear-ended, I think I was 18 when I first started driving, I was rear-ended by a big truck, and I was in a small car. Before that, I never would have worried. I just would have stopped at a red light and just kept going. Now, even at 46, when I stop at a red light, I directly look in my rearview mirror. Why? Because that's my response. After that, I want to see if it's coming. So that's a little T trauma, but if you think about all the other different abuses they talked about, that's something that you can tease out when you're talking with someone. If they say, well, before this happened, and then after that, I'm this way, but we may be talking about an experience of trauma. So something to remember and to kind of perk your ears up a little bit when you're talking with someone. Again, most individuals served in the public system have complex trauma. So we're talking about anyone who's been in the military, maybe even on the police force, any of these federal agencies, like there are opportunities where they've had complex trauma. And so there may be multiple sources, again, of trauma throughout our lifetime. Next slide, please. So what happens after trauma? Yeah, click it again to show everything. There we go. Well, sometimes we have just that acute stress reaction in the first 48 hours or shock, right? And then if it extends beyond that, then we're talking about an acute stress disorder, 2 days to 4 weeks after that, right? That would meet the DSM criteria. Let's say you're still having problems, but then you may have an adjustment disorder 3 months after that trauma, right? So I may have just described an adjustment disorder that I have because of the car wreck. And then there's post-traumatic stress, right? 6 months after the event, where you're experiencing those symptoms of the diagnosis, at least 3 domains, again, in the DSM. Then there's the complex PTSD, right, which is not indicated in DSM, but it's just that prolonged, more intrusive, significant impact on your quality of life that people are experiencing. And then there are other comorbidities, right? So we did talk about, as you have more ACEs, substance abuse is what they talked about, suicidality, hypertension, inflammatory diseases. Everything in that paragraph are some of the things or health outcomes that people have when they have a higher ACE score after those stresses in their childhood. So there are a couple of trajectories after the trauma happens. So this chart talks about level of functioning, going up, and then of course time across the bottom. So the adverse event happens, right? Well, there are different ways we can go. Most people go into impairment, right? Or whatever their response is to that trauma. Now, ideally, if they get the help that they need, talk with the people, are able to process the event, change the way that they understand the event, their perception of it, then there's a possibility they can go into resilience, right? The most effective thing that could happen is if you do that process and then you go into post-traumatic growth, where you've grown from this experience, right? You've been able to redefine it for yourself, and now you can grow from it. Now, that doesn't mean you lose the symptomology of trauma or PTSD when you have post-traumatic growth, but I think you understand it at a different level. You're able to process it better than if you're just resilient, and definitely if you are impaired by that event that happened to you. So, talking about resilience, right? Is used to study this resilience factor, right? The RF in humans. It is an inborn trait that can either be increased or decreased with activities. Again, if something happens and you do the work to help yourself process it, then you're increasing your resilience factor. Now, if we do the fight, flight, or freeze, right, when something happens, then what we're doing is we're decreasing our ability to kind of deal with traumas. And to be honest, as you decrease your ability to deal with traumas, I think you have more and more negative outcomes when the next trauma comes. Believe me, life is hard, and then you can see the world or perceive the world as unsafe. And then what would not have been a trauma, if you had a chance to kind of work through it, becomes compounding. Right? So there is a compounding effect as far as, like, if you think about interest when it comes to trauma and getting that help. So we are resilient, right? I mean, as humans, I mean, even when we were kids, we were resilient. And so we have that inherent in us. The idea was that, is there some place where we can kind of work on these things and get through them? And if there's not, then again, we won't see that. And so talking about post-traumatic growth, Tedeschi defined PTG as positive psychological changes experienced as a result of the struggle with trauma or highly challenging situations, right? This phenomenon should be considered not as alternative, but as a parallel process with respect to the negative psychological consequences. So it's a parallel process to you being impaired and post-traumatic growth. They're going at the same time. If you do get that help, though, you do increase your ability to be resilient. And so you then become or grow into that post-traumatic growth. So they run concurrent with each other. It just depends on the processes that are in place and the work that you do to get beyond that trauma that you experience. So speaking of trauma, and speaking of someone having a decreased resiliency, then they are more likely to be triggered. Now, what is a trigger? A story that one of my coworkers uses in our presentations is, why do they have fresh baked cookies at an open house? Does anyone want to answer that? Why would they have the smell of fresh baked cookies at an open house?
To try and trigger good responses for childhood or something like that, or grandma's house. Is that something?
Yes. So you go into this house, you're thinking of buying it, and you go in there and you smell something that smell like grandma's peanut butter cookies, right? Then you can feel at home there, right? Now imagine if you had smelled grandma's cookies and there was abuse going on at the same time. That same effect would happen. As soon as you smelt the peanut butter cookies, you would be drawn back in your mind to that place, whether there's a real threat or not. It doesn't matter. It's sight, it's things you see, it's things you hear, it's things you smell, which is a good indicator for us when we're working with veterans, and may even be a good indicator when you're working with an older population if they've had a negative experience in a hospital setting or with a community partner, right? Hearing that name, thinking about it, being in a place that's similar to it, that would trigger them to have a behavioral response would be not equal to the situation. And so how do you develop triggers, right? Well, when you're faced with danger, your body gets ready to fight, flee, or freeze, right? Your heartbeat gets faster, your senses go into high alert, you suppress your immune system, everything is, I need to survive. And I want you to imagine someone who is unable to share their traumas, and they are don't feel safe to share their traumas, no matter where they're at. And we never create that environment for them. What level are they at as far as sensitivity, right? Are they always in this hyperactive mode, scanning for danger? And then imagine how tiresome that could be, how that could drain on you if you're always looking for the danger, if you never feel safe. And this is basically the experience of someone who's experienced trauma and can't find a way to kind of process it. You know, any little thing can be a trigger. And so in care settings, what can trigger us? For example, let's say that you are a person who was in combat, and that's the population I work with. So I'll use it as an example. You were hit with an IED in your vehicle. The next time you woke up, you was in a hospital. People were standing over you, bright lights, 6, 7 doctors trying to see what's going on with you. Now imagine you got to have a surgery years later, and here you are in this spot, bright lights, 6, 7 doctors standing over you. You're no longer in theater. You're not at danger of being harmed, but your body correlates those two experiences as, here we go again. And so it's good to think about. I don't know the trigger does this. The one thing we do at the VA is on our psych ward, instead of having those beige plain walls, they painted like bookcases or different kind of murals, so that people don't feel like they're locked behind. The door is still locked, I'll be honest with you, but it doesn't feel like a prison, right? So what we're trying to do is create a sense of safety around that. And it's something as simple as that, that can help someone kind of get through whatever challenges they're going through. So imagine that and think about in your settings, you know, are there things that you think would trigger some of your clients? So again, some examples that I put here are TV shows or movies related to someone's traumatic event, a war, or if there was abuse. Like I can't think of, in my mind, I can't think of the name of it. Dear Mama, I think there was a video a long time ago where there was like a mother with a hanger, and I remember the little girl, and she would always try to be nice to her mother, not make her upset, right? So if you saw that video and you experienced that, any sort of abuse as a child, seeing that video brings you back to that point. Male or female caregivers may be triggered depending on the sex of the person who is perpetrating the trauma. We have a lot of veterans who may ask for a female provider, or they may ask for a male provider based on their experience. Again, smells and sounds and any apparent danger, or even physical touch. So even asking, hey, I'm about to do this. I need to draw your blood. Oh, I need to do this. Asking for permission, right? As opposed to just doing what you need to do, could help someone avoid being triggered, and it help you from going through that triggered episode that they would have. So they almost always come from the hypothalamic pituitary adrenal cortex, right? Fight, flight, or freeze. However, behaviorally, these can range from reenacting the experience, right? To regression to the stage that they experienced it. So if something happened to you as a child and you are re-experiencing, then you kind of regress back to the age where that trauma happened to you. And that's with executive function, and that's with all that, your behaviors to the response, like all of that kind of goes back to that time, which is why it's very important to kind of get some sort of mental health, some sort of psychotherapy, I'm sorry, and to kind of process that EMDR. There's a lot of different things out there kind of help you process it, to change not what happened, but to change your relationship and your perspective on what happened. Like, now I'm safe. I'm not 10 anymore in this house, right? I'm whatever age I am now, and I'm safe. I'm here with my mental health provider. So some examples from literature: a car crash survivor was relaxing in his garden when suddenly he became anxious and had intrusions of headlights coming toward him. Only later realized these were triggered by a bright patch of sun on his lawn. So something as simple as that. He's back there in a car accident. Or a victim of rape may feel extremely anxious while talking to a female friend in a restaurant, and only subsequently realize that their feeling was probably triggered by the presence of a man nearby who bore some physical resemblance to her rapist. So again, these experiences are imprinted on our mind, and then our base animal brain wants to survive, right? And so anytime that something kind of triggers that base response, and that's what happens, we go into survival mode. So I want you to think about how might a trigger response impact you in your current position? How might it impact you in your work? What would it look like if someone were at Trigger Institute and they had a trigger response? Because this is it starts with the individuals to begin to have that trauma-informed thought process, right? Before we can begin to kind of have trauma-informed medicine, or instead of just regular medicine where we pathologize, this is the symptom, this is the problem, right? No, what happened to this person? And so I would assume, and I think it's safe for any of us to assume, that every person we've come in contact with, the chart says 64%, that's 6 out of every 10 people you meet may have had a trauma. And so if you carry yourself in that manner, and if you interact with people in that way, I think what you'll find is a lot more adherence to any sort of guidelines that doctors may have. You may have people stop missing appointments, right? You'll have a greater outcome for you and your measures as far as what you are calculating as far as your people, if we are to take that trauma-informed stance. And so the next video is going to talk about this idea that I just introduced you guys to, trauma-informed medicine, right? What does that look like?
How can you ask someone about their body? How can you ask somebody about their mind and not recognize their experiences in the world as they're living in that body, as they're thinking and having that mind? It really is about recognizing people as whole beings and not just body parts. To me, that's trauma-informed care.
The majority of illnesses and conditions that people are treating in primary care settings are trauma-related.
There are things going on inside that you cannot visibly see, that if you don't ask about, it's maybe a barrier to the actual care that the healthcare system wants to provide.
We want to give people good care, but we want them to thrive. Not just be healthy, but thrive. And it's very hard to thrive in this community.
I experienced patients that were behaving in ways that were really stressful, cursing, yelling, really heightened emotions at the front desk, in my office, breakdowns. We might naturally ask ourselves, what is wrong with that person? Trauma-informed care is really about saying, what happened? Why would a person behave that way? I think one of the biggest frustrations that I've seen from my medical colleagues is frustration. Like, oh my gosh, I keep telling this patient the same thing over and over again. How many times are they gonna come in, not listen to what I recommend, and then have the same symptoms and then keep coming back for the same symptoms? If we ignore trauma in our practices, what we're gonna end up doing is doing the same work over and over again without having a different outcome.
I mean, our experience as providers has changed from being overwhelmed, from having a chaotic clinic, to an experience where we're feeling like we are doing the absolutely best job possible.
People come willingly. They're using more services, so they're understanding that their health is not just that medical service, but it's what they eat, how much you move, and the state of your soul.
But what we've seen is people kind of having longer periods of stability, and maybe they slip, but they get back in touch with us more quickly than they used to.
Once you start communicating and where you're not being dictated to, you know, someone is actually asking you, how do you feel about this? And how, you know, it builds that trust. You know, it's like, wow, they actually heard me, you know, and I see it.
Talking about and becoming trauma-informed does not have to be a traumatic experience.
This change process is incremental, and you can begin this as an individual person in your clinic and make a meaningful difference, not only to your patients, but to you as a practitioner. It's not radical to think that our job as primary care providers and why we went into primary care in all of our different disciplines is to actually help patients heal. I mean, that's not radical at all. It's self-evident, but it's like taught out of us. And what we're doing now in this movement towards trauma-informed primary care is to teach that back in, is to help people realize that their vision for why they went into this to begin with is to help people heal and to connect with them in that process, and to heal themselves in that process, and to have joy in that process.
All right, so a couple more slides about trauma-informed care so you can kind of understand the basis of it. The 3 R's are very important. Realizing the prevalence of trauma, that's why I'm here, that's why we're talking. Recognizing the effects it has on individuals as far as being involved in your programs, organizations, system, including the workforce itself. So recognizing that ACEs has an effect on each and every one of us on this call. Responding, right? We have to respond by putting that knowledge into practice, by being trauma-informed. And then resisting re-traumatization of veterans and staff, I should have just said of patients and staff, but of anyone we encounter, even if you're in Walmart, just realizing that, you know, the person beside you could have had a hard life, right? Just those are 4 R's, the pillars of trauma-informed care. And so the principles are based on safety. I talked about that at first. That's why I did it. Trustworthiness and transparency, right? Peer support. Is there some support around that are going through the same things? In my caregiver program, we have caregiver groups. So they're going through the trauma of dealing with the patient, their loved one who's having a failing medical, who may even have dementia, where they're having diminishing mental capacities. And that's hard, you know, if you spent 20, 30 years with individuals, to watch them kind of slide away. Collaboration and mutuality. I'm here collaborating with you guys, hopefully mutually on understanding this. Empowerment, voice, and choice. Empower people to make a choice, right? Don't just do your job. Empower them, right, to allow you to do your job. And then cultural, historical, and gender issues, which is what IDEA training talks about. You know, all the different cultural things around dealing with people from different ethnicities, different gender orientation. Like that's another part of being trauma informed. And so last slide talks about this thing I wanted to tell you about the trauma-informed medicine. What does that look like? Well, if we are trauma informed, right, under this umbrella, right, we are aware of trauma, then that allows us to be trauma sensitive, right, where we take the actions as an organization, as a system, as an individual to respond to trauma and its adverse effects. That can lead us to interventions, policies, procedures, organizational changes that are trauma specific, right? Where we can sustain the growth that we had around trauma informed care. It's very important that we have the awareness first, that overarching umbrella, so that we can begin to take the action and then put things in place that sustain the work that we put in, that we've done. And now the last slide, Dr. Yankee Love, would you do me a favor and ask me these questions?
Surely. So Lafayette, how are you feeling?
I'm feeling good. I feel like I may have talked a lot, but I'm a social worker, so that's something that happens. So, but hopefully you guys got something out of it. So I feel like I've been productive.
Yeah. And was your goal accomplished for the training?
Yes, it was. I love talking about trauma informed care. I love introducing it to people. I love getting people to understand that, you know, as individuals, as the one unit of information, that one input, that we can change the output for everyone around us. So it's very important that you guys take that away. So it doesn't have to be Dr. Yankee Love dropping the policy from the top down. It could be you where you're at now, doing something that's trauma informed. And then that, of course, will be the groundswell. And then maybe she'll drop some policy to come down as well.
Thank you. Thank you so much, Lafayette. So, oh yeah, there you go. Go
Yeah,
on
the
and-
last slides are just resources and then a way to contact.
Yeah. And as always, Justin will be sharing Lafayette's, I think, slides and or at least the video within 24 to 48 hours. Yeah. So thank you so much. You know, I've had the benefit of being able to hear your presentations on trauma-informed care, and each time I always learn things. I'm always taking notes. I'm always learning. So, and I appreciate being able to hear it again in different ways and different examples and those types of things. So, comments from our colleagues in our learning community, anything that really sparked something for you or made you think something in a deeper level, or how you're going to incorporate it into your practice or your care with your patients or your clients or even in your organization? I think while folks are getting their comments and questions together, let me ask you something. So if, you know, many of us work in a primary care environment or alongside of a primary care environment. I think that so many of the folks that come to our Project Echo are really involved in that whole health of the human. How can we help someone find a trauma-informed therapist? Is there certain ways that we can ensure that if we are working with a patient or a client, that we can direct them to the right person that would, you know, help them become resilient and grow?
I think that's a great question. To my knowledge, which isn't all knowing, I'm the omnipotent, but I don't know that trauma informed care is as widespread as it should be, even though it's been around for years. And so I think it's important, again, if you start on the individual level, and you being trauma informed with them could change your relationship with them. Now, if you have providers that are dealing with patients, I think there may be a good idea to think about, is there a way to incorporate that ACEs survey so that you know intentionally, hey, this person may have had something. And then, of course, I like what Bev Beckham put, talking about triggers, right? And so that would be a part of, once I know this person has had some sort of traumatic experience, right? I know something happened to them, then I can work around what those triggers may be, even talk to them about some of their triggers, right? Yes, the murals I think was a very, very good idea that they put up. I've been there since 2017. They weren't there when I started. And so a couple of my substance abuse patients did end up having some 24 hours or 72-hour holds. And so it used to be really, really drab in there. So the environment of care really, really matters.
There's lots of praise in the chat for your presentation. Alyssa talked about being involved in Eastern Kentucky flooding and does, understand the pre-flood and the post-flood, and it's a real way of life after such an experience, and was glad to hear that. Can you tell us more about some of the things that you're doing with caregivers and how you're incorporating your work there?
So a lot of my work, so I am the chair of the Trauma Informed Care Committee at VA. I have a co-chair, and we just redid our charter. So a lot of our work is starting with providers. So we do have 8 companies that were developed. Lori Paris helped kind of develop those, spearheaded those, and so I've kind of taken up the mantle since she's gone on to VACO, or central office. But we are presenting on those once a month, and those competencies are the prevalence of care. What happens with providers, what happens with staff, what happens with individuals, and then putting that knowledge into place. And the last competency is how can we change organizationally. With my caregivers, I do have a trauma-informed care slasher that I give with them. We have our annual open house next week, and then I'm putting in to do some CEUs out for the caregivers and the people who come, nurses and social workers and doctors, and talking about trauma-informed care and ways to care for yourself. So self-care is an important piece of this as well. I've talked about it before. Going to get therapy, working through this, that's very important. So with my caregivers, we do talk a lot about this idea of it can be again, it may not be something we can understand. It's their experience. It can be traumatic to watch someone kind of slowly not be the person that you know, right? And that's in your face every single day. And there's a powerlessness that comes with this. There's nothing I can do that will stop this person from experiencing the effects of dementia, right? And so what can I do to help myself kind of deal with this and still help them? And so we do have VA Reach is another thing that we use to kind of help them kind of process those feelings. It's not really trauma informed, but it's a way to give them some skills. And then once they have that skill base and the understanding of trauma, which that awareness is very, very important. I mean, then we can look at the things that are specialized just for them in their situation. So each one is different, but I think mainly me having that trauma informed posture when I talk with them and understanding that it's difficult what they're going through. I think it's very important to help people feel heard, because I have to feel seen and heard before you can do anything to help me.
Yeah. All right. Thank you so much. There's a few more comments, I think, in the chat. I think we're going to need to transfer to the case presentation. Is that, Justin, is about time? Lafayette, I hope you're able to stay and maybe give us some comments on this next case. If you're not, that's okay, but we'd love to see if we can have your expertise as we go through this case. Again, thank you so much for that. All right, so I think I'm going to pass the mic to, I think, Dina. Is Dina going to be presenting? Hi, Dina.
Hi. Yeah, I'm going to present a patient today that I've been working with for several years now. And there's, just as Lafayette was presenting, there's so many issues really that pertain to this patient that really go right along with his presentation. So just to kind of start off with an overview, this fella is a 66-year-old retired Navy veteran, and he was referred to me several years ago by Dr. Schaefer, who's a neurologist that we work with, for PTSD and PNES, and PNES stands for psychogenic non-epileptic seizures, which is a conversion disorder that's fairly common in folks with significant trauma, and it's a way that the body responds to the trauma and looks very much like epilepsy frequently. So he experiences a lot of significant psychological, behavioral, and physical symptoms related to trauma that he's experienced over his life. Some of this trauma is connected to his almost 30 years in the military, but he also grew up in a military family with a father who was deployed multiple times, who had significant trauma that was never discussed or talked about, and a lot of significant abuse within the household as a result of that. The way things were handled was very difficult for a young child to adapt to. So he's a combination of childhood, a lot of ACEs. I think he would probably have all of the ACEs almost. And then his significant experience in the military with exposure to trauma all kind of come together. Okay. Yeah, we can go ahead. You can go ahead and move on. because I think some of those other things. So just to review, 66-year-old white cisgender heterosexual married man, referred from Dr. Schaefer. Some of his other medical conditions besides the PTSD and PNES, he has hypertension, coronary artery disease, Barrett's esophagus, GERD, hyperlipidemia, sleep apnea, and supraventricular tachycardia. He was having a lot of cardiac symptoms, and he recently had a pacemaker placed, which has been helpful with that. But as you can imagine, those of us that have just experienced kind of normal day-to-day anxiety, how you kind of get that racing heart. If you have a cardiac condition that's making your heart race and you have a history of trauma, that was really interacted a lot with some of his psychological symptoms. So that's been a good thing. He also has a history of Hodgkin's lymphoma. He survived that several years ago. And at about the same time that he survived his cancer treatment, his mother passed away from cancer, and he has a lot of survivor's guilt around surviving cancer and having a mother that died really, I think it was within a year or two. And so there's also a really complex trauma really around that experience too. And he experiences what he calls mini strokes. And there's a little bit of confusion in this diagnosis because I think some neurologists have kind of leaned into the fact that those may be neurological things that are happening. But based on my experience with him and with Dr. Schaefer, a lot of these seemingly neurologic episodes that he kind of sees as mini strokes are actually the PNES symptoms. So it's a way that his body responds to this trauma when it becomes overwhelming. So he's 5'6", 237 pounds, blood pressure. There's some recent blood pressures from him, LDL and HDL and his A1C, just for some clinical measures. Okay, so background information. He has a lot, his symptoms, his PTSD symptoms are pretty typical. He's very easily triggered. We've spent a lot of time over our time working together, helping him identify and anticipate certain triggers. And for some of those things that he can expect, he's been able to kind of moderate some of his exposure to things to kind of be prepared for that if he knows he's going into that environment. But he's also had multiple experiences where a trigger is connected to a repressed memory, and it's not until the trigger happens and he has this very, very overwhelming reaction that then the memory has resurfaced. This has happened recently with a very specific smell, and he did not understand why that smell was so traumatic to him. And then after having the experience and spending some time processing it, he was able to attribute it to a memory that he had really, really suppressed. He describes all of these memories as, when he'll talk about it, he'll say it's in the way, way back. That's how he describes the things that he has suppressed in the way, way back. So sometimes those things come up for him. So his response to being susceptible to triggers is also really, really impacted by his day-to-day stress level. There's been a lot of family stuff going on with his wife's extended family that has created a lot of day-to-day stress. And he's noticing, and we've been working on that when there's an increased level of background stress, what some of us may consider just kind of the normal day-to-day stress, that really lowers his threshold with being able to respond to things that he might be able to kind of keep a lid on. Some of the ways that some of his symptoms, kind of physical symptoms that you might observe if you saw him kind of manifest. He has difficulty with his gait. He'll kind of freeze sometimes or get dizzy when he's walking. And this happens a lot when he comes into the clinic. And just to give an example of, I think at Traeger, we really spend a lot of time talking about being a trauma-informed facility and clinic. We had, I guess it's been about a year ago, we had a technology fair at the clinic. And this particular gentleman meets with me either every Thursday or every other Thursday, depending on how he's doing. And we come in the same way through the elevator, down through the basement. It's typically very quiet down there. Well, he came in, the elevator opened, and there were probably 50 to 100 people in this room that is usually an empty room. And when that elevator opened, he froze and he could not get out of the elevator. And so that's kind of an example of an environment that he is used to navigating and being able to predict those kinds of cues, really being blindsided by that. So we closed the elevator and we went back upstairs and we went into another room and kind of reprocessed, and were able to kind of get back down to the room eventually, because he does describe the therapy room that I use as his safe place, and he really likes being there. And once we're there and the doors are closed, he really feels like he can decompress and share things. So that's just kind of an example that really relates to some of the stuff that Lafayette was talking about how a facility, even a facility like ours that really tries to demonstrate really trauma-informed practice, can still kind of have moments where that we might kind of miss that. So difficulty walking with gait, freezing. He has a lot of trouble when things escalate with finding words. He'll kind of shut down. He'll start stuttering, and really just kind of check out when that happens. His difficulty with concentrating. He describes these checking out episodes. He will call them absence seizures, which is a type of seizure in epilepsy where people do kind of dissociate for a moment, but he describes becoming overwhelmed as having those checking out moments. One of the things that he's been no longer able to do, which was one of the joys of his life, was ride his motorcycle. When he started having these neurological symptoms, he does not feel safe on the motorcycle. And the motorcycle, getting out on his motorcycle and riding out in nature, was one of the coping skills that was the most helpful to him. And so he's really been struggling since this all began a couple of years ago, having to let go of that coping skill that was really helpful to him, because he's no longer feels safe doing it. But he denies any sexual problems and diet. He said it's not consistent, but he doesn't feel like that's really a priority at this time. So some social history. He has the equivalent of 3 associate's degrees related to his training in the Navy. In the Navy, he did a lot of different work over his time. He spent a lot of time out in the middle of the ocean on ships, and loved that. But he also was stationed in several places, and he worked in the military component of the Navy. So he was exposed to a lot of violent episodes and a lot of crime scenes and things like that in that capacity, and has a lot of triggers related to those experiences too. But he had a lot of education and training within the military. He has completed an advanced directive and living will. He doesn't have an official POA, but that's something we've been talking about with his wife. They have a very close, trusting relationship. They just need to kind of get through and make that official with the power of attorney. He's still able to drive. I mentioned that he does not ride his motorcycle anymore, but he still feels safe driving his vehicle. He did recently get a Jeep, and the intention of that is that he could maybe kind of take the roof off and at least kind of simulate some of that open road feeling that he would get on a motorcycle, but within the Jeep. He said it doesn't quite hit the mark, but that it's better than nothing. And in terms of economic stability, he's doing well. He has a significant pension that covers all of his needs, and he gets most of his healthcare outside of seeing me through the VA system. Okay, so no history of current substance abuse did I skip one? Oh, okay. No, at the time I'd made these slides initially when we were going to do this presentation a couple months ago, and something has come up in session with him probably about a month or so ago. At the time, in the 2 years that I've known him, he'd never talked about substance use, but he did share with me, I guess it's been about 6 weeks ago, that there have been episodes when he becomes more significantly overwhelmed, that he does use alcohol as a coping mechanism, as kind of a numbing. And he was finding himself feeling more and more tempted to kind of delve into that. But we've been working through that too, and he's feeling a little bit better about that. But his symptoms of anxiety and depression, as I mentioned before, go all the way back to childhood. He's one of, I believe, 7 siblings. He was always the smallest, and got bullied a lot for being a small kid. His dad had this really big kind of macho military kind of personality. And there was this big push, to prove that you're a man from a very young age. And he got a lot of positive reinforcement from his father for doing that. He tells a story. He's told a story multiple times about being picked on at school. And he he really physically assaulted his bully to a way that the kid ended up in the hospital. And his father was very, very proud of him for that. So he got a lot of really mixed messages about how to handle feeling vulnerable. And so he's really trying to kind of come to terms with that. And he also will say that, you know, it's really difficult. Some of the messages and some of the ways that we're sanctioned to handle something in the military is not sanctioned as a way to handle it in civilian life. And he really struggles to kind of navigate those two worlds. And so he's really, you know, as I mentioned, he's very still connected. And he, every single time when I meet with him, he says, you know, put me back out on a boat today. He misses it immensely. As much as it was a source of trauma for him, it is a core component of his identity. We actually talked last session. I said, if you had a pie chart of all the parts of your identity, how much of the pie would be, you know, connected to being, you know, an active duty military person? And he at that time said 80 to 85%. So that's still a very big component of his identity, and everyone in his family was in the military. He is active in his church and does a lot of volunteering in his church, and that is a really significant way that he feels engaged and gives back. And he's also a chairperson and in charge of the finances and a treasurer for a Christian biking organization. That's been difficult because that's been a really good source of support for him. But since he's no longer able to ride his motorcycle, there has been some pushback from some of the members of the group because they kind of feel like he's not, you know, legit anymore since he's not able to ride. We've been working through some of that because there are some members of the club that are very supportive and then just a few outliers that are not. So that's been a kind of also a source of support, but also a challenge. Let's see, he's married for 25 years to his second wife. His first marriage was also very traumatic, very tumultuous. While he was stationed elsewhere, he found out that his wife was very neglectful and abusive to their two daughters. And it took several years to get out of that marriage and then to get custody of his children. But there's also a lot of stress and trauma related to that time in his life. But his wife that he's been married to now for 25 years, that's a very, very healthy, supportive marriage. She is also a veteran. And so she kind of understands some of that dynamic, which is very helpful to him. He also has a really good relationship with his 6 grandchildren and is very actively involved in their lives too. And that's a source of giving back to him. There's one specific, just since we're talking so much about trauma and triggers, there's one specific memory that he shares frequently about when he was stationed, I believe it was in Italy, and he was the first person on the scene for a toddler that had fallen off a really high embankment. And he had held the child's head, and he describes it in a lot of detail, but the child was crying, and he is still very, very triggered by, you know, the sound of like a toddler age child crying. And so he talks a lot about how much he enjoys his grandkids, but how much easier it is for him to be around them now that they've all kind of grown out of that toddler age, because when one would get upset, he would want to respond, but had a really difficult time responding because of that memory. Okay. I already talked about the substance use, and we visited that. He has a service dog, and the service dog is probably the #1 source of support for him. The dog comes to sessions. This dog is amazing. It's so in tune with him that, you know, whenever we start to talk about something that's starting to get at something, you know, the dog is right up next to him. And it's a really good source of support for him, but it has also become a stressor because the dog is so protective of him. There have been some incidences where other people have thought that the dog has not bitten anyone or been aggressive, but the dog will intervene in a scenario where he feels like the patient is being threatened. And so he started to become really, really anxious about taking the dog certain places and I don't know, this is another issue that's really important to this demographic. A lot of people out in the world and a lot of environments do not know how to interact with service dogs. They see the cute puppy and they want to come up to the puppy and pet the puppy, and that's not what they're supposed to do. And so his dog understandably reacts in a protective way. The dog has never been aggressive, never bitten anybody. But, you know, when someone comes up and wants to pet the dog and then the dog does the dog's job, then people think that there's something wrong. So that's just kind of another element to his story that is interesting. And we've made some progress on that and things are going better. But there was a time where he was terrified that he was going to lose the service dog, which is his main source of support. And then we talked before about, diet not really being a priority to him. We talk about that sometimes, but most of the time in our sessions, there's kind of higher level things that we're talking about. He does take all of his medications. He does often feel really frustrated about so many pills. He really wants to be able to not take so many medicines. And we have talked about, other kinds of behavioral modifications when it makes sense that could maybe help reduce the need to take some of those medications. He sees a PCP cardiologist and other specialists at the VA. He sees Dr. Schaefer, who's the neurologist that diagnosed his psychogenic non-epileptic seizures. He's a U of L provider, but everybody else is at the VA. He's had several rounds of PT, OT, and speech therapy at the time of when those mini strokes were diagnosed that ended up being the psychogenic seizure episodes. But still, even with that kind of a diagnosis, the physical therapy, occupational therapy, and speech therapy is very helpful in treating that because it helps him kind of manage those physical symptoms in a more specific and directed way. All of his medications are covered through his VA benefits. He's been working with me for a little over 2 years. He does sometimes report some frustration over his overcare at the VA just because of, turnover and things like that. He did see therapists for a while at the VA, but he said in the office where he was going, there was a lot of turnover. And as you can imagine, somebody with significant trauma having to kind of restart and retell your story with a new person every 4 or 5 months started to feel like it was difficult. So we've been able to be now consistent for several years, which has been helpful. And he has access to dental benefits and sees dentists regularly, so that's not a concern. Fall hazards, the gait instability, that is another thing that his dog is very helpful. He's a really big, tall dog, and when he's next to the patient, he's about hip height, and he will walk right next to him, and they have this kind of command where he gets unsteady, and the dog will stand. He can use the dog to brace, so he uses the dog a lot for support. Home hygiene, I haven't done a home visit or anything, but that's not been a concern. And he's always, well groomed and appropriately dressed, has all the environmental things in place in his home. Let's see. So in terms of collaboration, I've had a lot of collaboration over the years with his care with Dr. Schaefer, who's the neurologist. And so in terms of treating the PTSD and the psychological and physical symptoms associated with that, we've had a lot of collaboration. He and I oftentimes do discuss his experience in appointments with other kinds of providers when he becomes frustrated with something. And, we use our sessions to kind of process some of that. I don't have direct access necessarily to those providers to do the kind of collaboration that we can kind of when we share office space, but we process a lot of that in session. And so that's been helpful for him too. He also participated in, when we had art therapy students last year, he participated in the art therapy group, and he absolutely loved that. He and his wife both participated in that, and it still comes up, I would say, every few months. He'll talk about how beneficial that was for him. So much so that I've been looking into finding a resource for him to be able to attend art therapy, especially with, I mentioned before, when he kind of shuts down and it's hard for him to articulate verbally a lot of what he's experiencing. He really enjoyed being able to express some of that in other ways with art therapy. So we're looking into finding other ways for him to reconnect with that. But as I mentioned before, he has benefited in the past from physical therapy and occupational therapy for some of the other physical symptoms. And this is just a list of his medications. And then, in terms of questions, I don't necessarily have, specific questions around him. I think there's so much overlap with his case and what Lafayette presented. I think he's a really good clinical example of a lot of the things that were discussed in terms of trauma, going back to ACEs, a lot of his childhood trauma, and then multiple traumas over the course of his life. And so I think, the first question I said is how to ensure physical comfort, safety, and clinical settings for trauma survivors. And I use that example of us hosting that tech fair and not really considering that. And I learned a lot from that environment. And now if I know that there's some sort of event going on, I know to warn my patients, next week when you come, there's going to be a lot of people here because we're hosting a, whatever. So I've learned personally, and I think as a clinic, we were learning that we need to advertise that better to our patients, where something like that we look at as a great thing. Look, all these people are here doing this stuff, which is great. But for some people coming into our clinic, that could be a surprise and it could be a trigger. And then how to support trauma-informed medical inquiry for patients with complex medical conditions was the other question. And I know Lafayette touched on some of those things in his presentation. But if anybody has any questions, suggestions, insights.
Thank you so much, Dina. Yeah, it does really demonstrate all the things that Lafayette was. Lafayette, did anything come to you or come to the surface as you were hearing this particular case?
Yeah, there were a couple of things that I kind of wanted to speak on. I think sometimes when we survive trauma, we're always looking for safety. And so it's difficult to find safety in change. But then again, it's difficult to find any moment or place in our lives where change isn't inevitable. And so a conversation just around, the inevitability of change, and especially with the frustration with the VA providers. I think that every year or so, people will kind of change, either moving on or change positions. That's just so they don't get burned down. It's not meant for the patient to kind of get the short end of the stick. And most of the time, the patients end up getting the short end of the stick because I think the changeover could be better. And I don't know if this is something that we're already addressing at the VA or not. I'm not in behavioral health, but I do think that's something that they are looking into. And it's something that I believe could be kind of, we can kind of hedge our bet on that, so to say, if we were to speak with them at the VA, if he has a provider there, just about the ideal that, I'm on this journey with you until I'm not on this journey with you. And so this idea of, his journey throughout his life, wherever he's going to, we are really just passengers in his vehicle. And this is how I've always explained it to my substance abuse people when they've moved on. It's like, I'm along for the ride until, you need to get it, until someone else needs to get in. It doesn't mean I'm abandoning you or leaving you, but change is something that's going to happen anyway. So if you're trying to change your life, you have to realize that change is going to happen around that. I think it would be really important. You did talk about the collaboration with the providers. If there was a release of information or something in place, and that would be him putting that paperwork in, where you can kind of talk with those providers about, hey, from my standpoint as a clinical provider, this is what I'm seeing with this patient and kind of what he's going through as far as trauma. Now, everyone's not going to have that information as far as how to do trauma-informed care, which is the reason for this training and the reason I'm doing it at VA. But to be able to talk with them about, hey, this is how this person presents, could maybe raise, again, that awareness for them. And then his interactions with the providers at the VA could change or at least evolve. And I think the last one was, again, it kind of points to that, the medical inquiry, like we need to be able to talk with each other as social workers, doctors, neurologists, whatever. If we have a patient that's having an experience, to be able to say, hey, let me speak with you about this patient's experience. It's not to try to correct them in what they do, but to kind of make them aware of that, some of the things that we do have negative effects. And so I don't know if they incorporate, and I don't think they do incorporate the ACEs, but that's going to be the greatest thing. Case conferences is another good example. That's going to be the greatest thing that's going to help us is knowing what's in front of us, because we don't know what we don't know. So if you don't have this idea that this person experienced trauma, then some of the things we do unintentionally will re-traumatize them or at least trigger them.
Thank you. Thank you so much. I think, Bev, you have a question or a comment?
Well, it's just a comment about the frustration related to the change from one provider to another. So, and I'm sure they do this, but this was the first thing that came to my mind. Obviously, the medical record has a lot of information and care plans and all those kind of things. So before beginning with that new patient, client, whatever you want to call them, is, couldn't that person just review the medical clinical record just to be a little bit more familiar with the case so that they don't have to recreate the wheel there?
Yes, I think they can. I think in some of in our trauma clinic, I don't think they have people redo their story unless it's part of a specific intervention. Like they're doing this intervention, write the story just to kind of reduce the symptomology and reactivity. The thing that I've always done, so if someone was doing substance abuse or case management before me, is I would come in and just ask the person what's really important to them. So, I mean, I could learn a lot from a chart, right? And this kind of goes back to my time as a case manager in Veterans Treatment Court, is that my experience there was offender did this crime and that crime. And so I read what they gave me to read to know the person. But when I met the person, I met the person, right? And so I just tried to connect with that person on that level. And then if it gets to a point where something happens where he's re-traumatized or triggered, then that could be the time to kind of delve back into the story. What kind of brought about that? But I don't think it's necessary that everyone kind of retell their story again and again and again, because that can be a barrier to someone engaged in healthcare, especially mental health care.
So the presenter had just mentioned, that was something that frustrated him, was the change from provider to provider. So that was the reason I mentioned that. The other is, I do think weekly case conferences, or however often you recommend, I think getting the team together to do team-based planning. I've worked with community health workers for several years, and one of the most effective tools that I have found is the interdisciplinary care team, because everybody brings a different piece to it. And a community health worker can almost always supply information that the people that with the licenses above him or her don't know, because there's such a trust factor there with the community health workers.
There's a separation when you have someone working with you versus the clinician, right? It's just that power differential, and then their comfort level sharing those things. For us, it's the peer support. So if you have a peer support, a veteran talking to another veteran, they would get a lot more information processed than if it were a veteran coming to me as a therapist, but then that peer support would talk to me. So again, maybe getting some of those release informations put in place with those providers at the VA, you can kind of speak with them, even maybe schedule some time with them would be ideal for this client, just to try to help have that holistic support.
Thank you.
Yeah. Thank you. Is there one other question or comment before we transfer to the KCHC meeting? Is there anything? I did want to say that, Dina, when you talked about the environment, that's so important. We actually, there's somebody now that I feel at the front desk who lets people know that there are other things going on in the space and lets you know that there's noise and things like that. And yeah, I never thought about that. So when you said that, I was like, oh yeah, that was probably very jarring for many of our patients and clients. So yeah. And I was recently in a meeting, recently, probably in the last 3 to 6 months, with an art therapist at University of Louisville, who's a faculty member who had some a variety of things that they were doing. So maybe we can connect you to that particular person, because maybe they would have some programs that would benefit your patient. Thank you. Thank you so much, Dina, for presenting your case in Lafayette. Thank you so much for your presentation. I think we're going to move now to the KCHC part of the meeting, and I'm going to pass the mic to Justin.
Thank you, Pam. Thank you, everyone. I just want to highlight a lot of the comments in the chat, just kind of reframing certain things that Lafayette shared, during his presentation, and then, commenting on Dina's presentation. I mean, I think they melded together very well, and highlight just the real need for us to be aware and know how to respond to people who have experienced trauma. I really like, and several people commented in the chat, of reframing this from what's wrong with you to what happened to you, to really, humanize this. And I think that lots of people really resonated with that, Lafayette. So we really appreciate it. Just a reminder, the purpose of the KCHC is to train and empower stakeholders and community members to provide hope and education for their communities. So we really hope that you are taking this back to your community. We're taking this back to your organizations, and that, you can bring other organizations to the KCHC so we can continue to really strengthen the workforce and really help people understand these really important concepts. We're running really short on time. I think I shared a few things that we learned today, but I really encourage you and invite you to really think about how you're going to take this back to your community and share this. I will be sending out a recording of today's session. It'll be up on YouTube. I'll be sharing resources that Lafayette shared. So please, you're always welcome to take this out into the community. And if there's ever anything that you've heard that you would like additional resources, let us know. Our ears are open, love to engage you and find ways that can keep this conversation going, because I do realize that this is, Lafayette, would you agree this is not a one and done conversation? This is a multiple, probably lifetime experience of learning how to integrate this.
Oh yeah, I think we're building the foundation. We're framing the house, but even when the house is built and the driveway is poured, there's still maintenance, right? And so in order to sustain it, we definitely need to kind of continue to have this conversation again and again.
Thank you. And I saw Bev say that she would share this with her colleagues. I really appreciate that. So this is an opportunity. If you have any events in your community, feel free to share that in the chat, or you can unmute. If you ever have flyers for events that you'd like to share, you're welcome to share them with me before the meeting. And we would be welcome, we would be happy to share that, just because we really, again, want to be highlighting the great work that you're doing in your communities and connecting to other organizations and individuals who are passionate about this type of work as well. So, okay, thank you, Bev. Yeah, so do you want to unmute just for a second, Bev, to talk about the conference?
Right. So the KAYAC is what it's called, Kentucky Association of Community Health Workers, has an annual conference for all the certified all the community health workers or anyone who's interested within the state. So currently there's about 350 members of that organization. 325 of them are certified community health workers, and many of them have received their training there at the Traeger Institute. So on an annual basis, there's a really great conference. It's held at Griffin Gate Embassy Suites in Lexington. So I can share more information about it when it comes out as far as registration. It's a really good learning opportunity. And if you or any of your friends are interested in community health work, we would love for you to come.
Thank you, Bev. And we'd be happy to share more about the conference when the materials are out. And I encourage anybody else to, share anything in the chats, and we'll try and highlight that in future emails. A few things going on at the Traeger Institute. If you know anybody that needs help managing diabetes, we have a project with See Yourself Health. You can join a research study to learn more about managing diabetes. We have a variety of classes. I know Mona will be starting another Flourishing Together class in the fall. And then we have some programs for both patients and their loved ones. We have a virtual friendly visitor program, a lot of different services to really try and meet the whole individual. My Health Matters meets on Monday evenings from 6:30 to 7:30, and they sort of have more of a fun agenda for the summer. So you're more than welcome to join Mona and her group of presenters for sort of an enjoyable Monday evening through June and July. And Mona walks with the doc on the first Saturday, at 9. And so there's some more information here. Of course, if you ever have any questions, you're more than welcome to email myself or Mona. So again, in closing, we really want to be a statewide coalition. So really encouraging you to invite and connect with other community-based organizations. Our intention really is to empower people to be healthier and compassionate. And so this really is only possible through our mutual collaboration and working together. Hoping you feel, it feels more like late August than it does June. So it's a very hot June already, but just really encouraging you to really, celebrate and take care of yourself as we move into the summer. If you are a community health worker and need community continuing education, you really need to complete this survey. We really encourage everyone to do so because we really value your feedback. And Project ECHO and the Kentucky Coalition for Healthy Communities will be taking a break in July and August. We'll be returning in the fall, so please be watching for emails with our fall schedule, and we hope to see you then. As always, if you ever have questions, comments, suggestions, please reach out to myself and I'll connect you with the appropriate resources. Really appreciate everyone being here today, and we really appreciate Lafayette and Dina for sharing your expertise. So I'm going to stop the recording, and I'll hang out for a few minutes. If you have any questions, please hang out. Otherwise, I hope you have a great rest of your day. Bev, I will do that. Give me just a second. I'll stop sharing and I'll put the link in the chat. Give me just a second. Thank you for the reminder.
Thank you everyone for coming. And thanks again, once again, to Lafayette and Dina.
Okay, so I'm going to go back to sharing my screen in case you still need the QR code, and I will put the link in the chat.
Thanks so much, Trigger. I'm going to get out of here and go on to the next situation I have to handle, but I appreciate the opportunity. Hopefully you guys learned something, so I would love to do it again if you ever need it.
Thank you. Thank you so much, Lafayette. Appreciate you.
Okay, thank you, Dr. Yankee Love.
Thank you, Justin. Appreciate it.
Okay, so I'm gonna end the meeting. If anybody needs any help or anything, please, I'll be sending out the email later today, but you can ask when I email the group. So everybody have a great weekend.
Bye-bye.